enter the room.
Okay. Just a second. Okay. Hi, I am Dr. Rasmi. I am an OBGY doctor and I'll be seeing you today. Are you Maya Radfil?
Yes, doctor. I'm Maya.
Is it okay if I call you Maya?
Yeah, that's all right.
So, hi Maya, how are you feeling today?
Yeah, I'm doing great, actually.
That's good to hear. Have you been experiencing any discomfort lately?
Um, no, it's been going well. Yeah.
Great. Now we are in the third trimester, and it's coming close. How are the nerves and how are you feeling in general?
I mean, since you actually mentioned, doctor, I'm actually starting to feel a little anxious about the delivery date approaching.
I can understand, but Maya, I want to reassure you that we are going to try and make it as comfortable as possible for you. And
Uh,
I can teach you some deep breathing exercises. You can try meditation, and I'm sure that can help you. Have you been doing any preparatory classes for your birth?
yeah, I do all that. That's absolutely fine. Yeah, I go for these
That's
basic classes.
that's great to hear. So Maya, have you been feeling the baby moving well within your
Oh,
belly?
oh yeah, he's a pretty active one.
That's great. Have you been having any discharge, any pain in your abdomen? Or
Um, Nothing out of the usual.
great. And have you been taking all your supplements, your calcium, your
Mhm.
iron?
Yeah, I've been taking all that regularly.
Great. So I'm just gonna go ahead and examine your abdomen. Just gonna make sure that the baby is growing well. All right. And for the examination, I would like to check the fundal height, the lie of the baby, the fetal head. Uh, I would like to check if it's engaged, and yeah, that's about it. I would also like to check the patient's vitals, including the blood pressure, uh, a urine protein dipstick, and I would also like to request a CBC to look at the hemoglobin. Um,
Sure.
and I would also like to perform a dating scan. Great, we have the vitals. So great, everything looks good. Patient appears well. Not breech presentation with the head palpable at the fundus, the feet hard. Good. Head visualizing the fundus. Great. Okay, so Maya, what I can feel is when I feel your belly, I feel that your baby's head is up high and the buttocks are towards the bottom. The baby's breech. All right. And that can sometimes make it a little hard to deliver the baby vaginally. So, what I'm gonna do for you is I'm gonna schedule a follow-up for after a week, and I'm gonna see if the baby turns upside down in the coming week because that can happen in many cases. So, yeah, that's what we're gonna do.
Wait,
Um,
I'm not understanding what's happening. What do you mean my baby is in breech? What does that mean?
Oh, it's nothing to worry about. So usually for the baby to be delivered vaginally, we want the baby's head to come out first and the buttocks and the legs to come out last. But sometimes the babies they like to sit up straight in the belly, making their heads come up towards your upper abdomen and the buttocks coming towards the lower part of your abdomen. So if that is the case, when you're delivering the baby, the buttocks come out first, and it can be a little stressful for you as well as the baby. So, which is
So,
why I wanna, yeah, I'm sorry, go on.
so what happens now? I mean, do you have any options to turn the baby? Something, can you
So there
prevent?
are there are a few things that I would like to do. I would like to schedule a follow-up for a week later to see if the baby has turned. And if the baby doesn't turn, we can do a maneuver where uh, I or another doctor will turn the baby upside down um, while pressing on your belly. All right. So basically, we'll gently nudge the baby's head towards the lower part of your belly and gently
2 minutes
nudge the
remaining.
buttocks to the upper part of your belly so that the head is in the lower part, right? And the baby is not breech anymore.
And is my baby going to be all right, doctor? Yeah.
We will, throughout the whole process, we will be monitoring your baby's heartbeat, and we'll also be monitoring you, and we will be making sure that the baby is safe as well as you are safe.
Okay. All right. Sure. And can it be delivered normally? What happens if the maneuver fails?
Well, if that happens, we can what we can consider going with a cesarean section, um, so that the delivery is a little easier. But you can also choose to deliver vaginally. It just makes the delivery a little harder, but it's definitely not something that is um, very dangerous for you or the baby. But if the maneuver fails, we could be considering a cesarean section.
Okay. Yeah, I'm a little worried, doctor. What can I do from my side? Can I help with anything to move this process along?
Maya, listen, this is absolutely not your fault, and this is a very common presentation. We see it every day. All right. You can just continue to do the things that you were doing before. Everything else looks completely good. Your blood pressure, everything is in check. The baby's weight is in check. So you can just keep on doing what you were doing. Keep on practicing mindfulness and meditation,
Move on to
and
the next
keep on
station.
taking your supplements.
All right, good job, Dr. Ashmi.
Yeah.
That
Wow,
was
that
that
was. I'm
was
sweating.
oh,
Well,
no,
thank you.
you did a good job, I have to say. So yes,
I'm
let's
glad.
talk about how this case should actually be ideally done. So you started with
Great.
a lot of
Okay.
points where you
Great.
were asking about her current condition and if she's
Yeah.
experienced any complications, right?
Yeah.
So
Yeah.
whenever you start with a consultation, try to start
Yeah.
with an open question. You
All
know,
right. Okay. Yeah. Great.
whenever there is a patient who comes to see you, they might definitely have
Yeah.
something in their mind, right?
Yeah.
And
Yes.
explore if there is something that is something that you want to address right away, right? So
Right.
always ask, what is the purpose of the visit? That is a very good
Yeah.
question. Um, so
Right.
or always, if you have the candidate information in front of you, you know,
Right.
and you can see what is the purpose of her visit, where she's come with her routine checkup and where she's coming for a
Yeah.
routine. Use the information, right? Because candidate
Got it.
information is similar to the doctor's notes that you would be having, right? You would be having some preliminary information about this patient, so use that to your
Mhm.
benefit, right? And
Great.
start with the consultation. That way you won't have to ask additional questions. So I can see from my notes that you have come in for a routine antenatal checkup and it's your 13
Right.
weeks. Is that correct? Always whenever you're getting facts from your
Yeah.
candidate information, always corroborate it with the patient themselves. Check with the patient, like ask her to confirm everything that you have. All right,
Great.
this is
Good.
actually a
Okay.
visit. Definitely you would want to check with the patient. So in the
Mm-hmm.
beginning itself, you have to do that by checking for the name and the age. So always patient identifiers, make sure to ask the full name and the age, right? Because that's what tells you who the patient is. So good job
Got
on
it.
doing that, right? And then ask about, start with an open question. So I can see from my
Mm.
notes that you have come for your routine antenatal checkup. So could you tell me a little bit more about how your pregnancy has been going, right? Because that's what you're
Got
doing,
it.
starting with your
Yeah.
routine, right? So let's hear from her how her pregnancy has been so far. Right. Similarly, if you have, a presentation with a disease, where if a patient has come in, maybe say with a headache or maybe a leg pain, explore it with an open question. Because even if they do have a headache or a leg pain or the acne in the last case that we saw,
Hmm.
understand why they came to the hospital, right? Not every symptom brings the patient to the hospital. So you want to actually see what prompted them to come to the hospital. What was that main pressing concern? All right.
Correct.
And that is the importance of open questions. Always start your consultation with the open questions. It answers a lot of what the disease could be, right? Right off the bat, you could actually understand what this case is all about, right?
Got
So
it.
so starting with understanding, that this lady has come for a routine checkup. Yes, now we have the case that this is a routine checkup. You start by asking about how the normal pregnancy has been. Has she been experiencing any? And this is 36 weeks. So you mentioned something along the lines of dating scan, right? So when is dating
Yeah.
scan done?
So, the thing is that what I don't understand is that as an OBGY doctor,
Uh-huh.
the thing is that where I am working, we do dating scans for every visit. So, a dating scan for us would generally mean looking at the baby's weight and assessing it every couple of months or 3 months. So I was a little confused there as to whether as an OBGY doctor, am I expected to be doing that or bringing it up, or is it like a different
I,
visit?
so we continue. What do you understand by the word dating scan? Like, what do you
Uh,
understand when you call it? Is there any other types of scan you have heard of apart from
yeah.
dating?
So where I am, we do a congenital anomaly scan for high risk
Oh,
patients
okay.
at 24 weeks, and all the other scans are loosely called dating scans, where we just uh, look at like the gestational age corresponding with the baby's weight and the head circumference and the biparietal diameter, and we just look at what the expected date of delivery is, and we also look at the AFI and the placenta and things like that. So,
Absolutely. All
uh,
right. I'll just interject you here. So those are
okay.
all to understand if there is any IUGR, right? Like intrauterine growth restriction or something. But when do you call it a dating
Mhm.
scan? When you actually do the first scan in the first trimester, that's when you actually start calling it a dating scan. Because when you call it dating, you're telling them when is the expected date of delivery. That's when you're actually telling them about, when are you going to deliver. So that is immediately in that first
Mhm.
trimester itself, you can tell them when it's going to be delivered. The rest of the scans will be actually looking for any anomalies per se. But in the UK, you usually limit yourself to doing just 2 scans, right? There
Mhm.
is certain evidences that mention that,
Mhm.
multiple scans is kind of not a very good practice.
Okay.
So if it is high risk, do they
Okay.
actually the kind of scan? So the other scan, so dating scan
Okay.
usually done
Okay.
in the first trimester around 8 to 14 weeks. Anomaly scan is usually
Okay.
done around 18 to 21 weeks. So that's when every
24.
child has to go through this scan because they're trying to look for any
Yeah.
high pregnancies. You wouldn't know if it's a high risk pregnancy unless you do this scan, isn't it? So just wanted to
Mm.
clear that up. So at this point,
Okay.
this patient has come for just a regular checkup, right? So you just want to make sure that everything is fine. She's not been experiencing any complications during her pregnancy. What would be the complication around 36 weeks that you should be really, really concerned about?
Antepartum hemorrhage,
Or-
placental separation,
Yep. But what is something that's really common?
preeclampsia.
Absolutely. That's what you have to, those are the risk factors, those are the red flags you're actually looking for. Any severe abdominal pain, any blurring of vision, any intense nausea, vomiting, any signs of hypertension, edema and all that. Right. So
Got it.
understanding that this patient has come in the 36th week, those are the things because
Mhm.
she's getting ready for pregnancy, I mean delivery, right? Anything
Yeah.
that can actually cause her any distress during that last lap, you need to quickly rule out,
Yeah.
right? And
Correct.
so mainly in this scan now, so that's why you're asking your routine questions like how was your pregnancy gone so far, have you been experiencing any complications during your last visits, were you told about any complications, because you need to be really aware of what you're looking into, right?
Correct.
Is there anything that she has been told to be worried about? Does she have anything like placenta previa or low liquor, right? Because when you, by the time you get the diagnosis, you're only getting this diagnosis when you do examination. Before that, you have no idea what this case is, isn't it?
Got it.
So now, when you see
Correct.
that there is a pregnancy which is currently presenting in breech, what is the things that that should be going on in your mind? Like, what are the risk factors for this patient to have a breech pregnancy? Number one. Number two, why hasn't the baby turned yet? That's the first. Usually, what is the time that you're expecting the baby to be in the cephalic position? Around 28
And
weeks,
yeah,
right? So
third times.
also by 32 weeks also, by 90% of patients actually are the presentation is usually cephalic by 36 weeks. So now you
Yeah.
see that this is one of those edge cases where it's not cephalic, it's in breech presentation. So now you're a little worried because delivering in the breech presentations comes with its own set of complications, right? And you just want to make sure that she doesn't have to undergo any of that. So you're going to talk about the external cephalic maneuver where you will be turning the baby initially in in a week
Got
or so. It can happen in the current visit, it can happen after 2 days, it can happen next week, because within that 36 to 37 weeks you're just trying to make sure that the baby does turn, right? You're going to try helping the
Mhm.
mother out a little bit from your end, right? But
Yeah.
even before
Yes.
you are going to offer this maneuver, what should
Yeah.
you be ruling out? Can you offer this maneuver to everyone? Like, shouldn't you look for certain
Mm.
risk factors which could be contraindicated for this, right? So you need to look
Correct.
for any signs of distress. Is the mother in a state of delivering at this point? Is the
Mhm.
baby in a state of distress? Is the baby hypoxic? So even before you start the maneuver, think about doing certain prerequisites. Do a CTG just to
Okay.
make sure the baby is healthy. Because even during the maneuver, you will be making sure to, making sure for, the monitoring. That will be
Got
something that you continuously be doing throughout the maneuver, right?
right.
But even before
Yeah.
that, you have to make sure that she doesn't have a low-lying placenta. There is no usually these kinds of cases where the baby does not present in cephalic usually occurs with high as well as low liker, oligo as well as
Mhm.
what is the other
Poly.
thing?
Poly.
Polyhydramnios. Yeah, absolutely.
Correct.
Yeah, so certain prerequisites that you will be mentioning, and then immediately if this doesn't work, because it has a 50% chance of working. If it doesn't
Correct.
work, then you're going to offer, right? So
Yeah.
according to COG, you actually offer them for a cesarean section. That is a more safer option. But if the patient demands that they want to go in with the normal vaginal delivery, then you can talk about that as well. And mention that it comes with its own set of complications and risks, right? Then
Correct.
you kind of mention it to them, get mention that this is also a possibility, but with its complications, right? Making the patient very well aware of the choice that they're going to make, right? So that is the whole point of informed decision. All right. So that was about this case. Let's quickly look at the performance. and how it is. So we have a checklist for every case where we have divided the checklist into data gathering, management, and interpersonal skills, where, depending upon the consultation, we put down points of all the points that were covered and missed, and, you can dynamically see how you can perform each case. So each case is saved according to the date and time of the practice, so that you can actually go back and check out how, to perform these cases in time and how well you have been improving. All right, so let's quickly look at data gathering. Conduct an abdominal examination that was mentioned, so partially covered. Ask the patient's full name and age. This is very important. So this is to make sure that you are talking to the right patient. So every time, even if the patient does tell you my name is Maya, make sure to get the full name and the age. These are your identifiers that you do not want to miss, right?
Okay. Yes.
And yes. Inquire about the baby's movements, pain, contraction, or any fluid loss, So that is something that you can start with an open question where, how is your pregnancy going? And if they'll just give you a very generic answer, like, yeah, it's been going well, then close it down a little to make sure to understand specific things that you're looking for, any red flags that you want to rule out. Right? Have you been experiencing any contraction pains? Have you been experiencing the baby's movement? Because even if the baby is not moving very often, that's also a sign of distress that you would want to explore, right? Any fluid loss during this time, right? Ask about current pregnancy details and any concerns. This is your open question. Review current pregnancy, ask about antenatal visits, scan fetal growth or any complication noted so far. Obtain full obstetric history. If this is her first pregnancy, right? Ask about any past pregnancies, any deliveries, or any deliveries or any complications. So these are other risk factors for why the patient would not present in a cephalic position, if they have multiple pregnancies, right? Explore prenatal history for any identified abnormalities or complication. Discuss patient's birth plan and preference for delivery, right? These are all things that they already have in mind, right? So you asked about, how are you coping? I'll be teaching you some meditation techniques. I mean, those are kind of not important at this point, because as a person who is, catering to a patient on a routine follow-up, you need to rule out any, medical related issues, right?
I have a doubt here.
Yeah, sure.
So in the case that was provided to me, there was a section that said that there is no significant past medical history or complications in the current pregnancy.
Mm-hmm.
Uh, so even though that is written, do I still have to ask her about diabetes? Because that, I mean,
Like that is something that was kind of, that's what I'm telling you. This is something that is
Mhm,
related to a patient's chart, right? You have to
mhm,
confirm it from her. Like, have you been experiencing anything? Have you had any past medical conditions, any medications issue? What about allergies, right?
mhm. Right.
So
Okay.
definitely, even though, so this is something that you kind of have an idea about, but always, to be really sure about something, you have to ask the patient always, confirm all the details that you have with the patient itself. Maybe in the form of a
Okay.
question, or maybe by, starting with that statement where you can just say something like, I can
Mhm,
see from my notes that you are on your 36th week of gestation. Congratulations, right? That way you're kind of giving the
mhm.
information. In a way, you're actually sharing that information that you know, right? So you have to show the fact
Okay.
that this is one of the data that I gathered, right?
Okay.
Awesome.
Okay. Yeah.
All right, because these are all the risk factors that you have to keep in mind of why, the patient is not encephalic,
Mhm.
right? That you can actually,
Yeah.
because if there are any complications, then the whole management plan would differ. It can completely change. All right, so medical, discuss the birth plan, preferences of delivery, right? So this is something that they'll already have,
Mhm,
right? So always explore that.
mhm,
Explore medical and surgical history, rule out medical conditions like gestational diabetes, placenta previa, previous surgeries, medications, or any known allergies, right?
mhm.
Also Also, you can ask about the family history, has anybody in your family faced any complications? Again, that will be a big risk factor when it comes to preeclampsia, right?
Right.
Gather lifestyle, psychosocial history, inquire about smoking, alcohol, support at home, work status, diet, ask about exercise, right? These are all important questions to understand, if there is going to be any complications in the coming delivery, right? Perform a general physical examination, check mother's vitals, including blood pressure to rule out preeclampsia and inspect for peripheral edema. I think you did this point. I'll give you marks for that one. And finally, conduct a general physical, abdominal examination. So this case can actually present as an examination station where there will be a mannequin and you are required to do the different kinds of grips in this case, right?
Correct. Correct.
And ultrasound is also, if you do understand that it's in 36 weeks, it
Yeah.
is in each position, you have to confirm it with an ultrasound. All right.
Yeah.
That is
Yeah.
the next step. As soon as you understand it's breech, you have to confirm that with an ultrasound. All right, management. Explain breech presentation commonality before 36 weeks. Explain breech presentations clearly. Explain in simple terms to describe how the baby is lying bottom first and why that matters, right? This is very important. Like, what is the significance of having a breech presentation in 36 weeks? That is something that you want to communicate with this patient, right?
Yeah.
External cephalic version as an option, explain how the baby can be manually turned through the abdomen and when it's typically offered, right? Explain the next steps if ECV fails, describe how a planned cesarean is usually recommended for persistent breech at term. Discuss delivery options, vaginal breech delivery versus planned cesarean section. Discuss vaginal breech delivery, explain that it's rarely done and under strict conditions in specialist unit due to its safety concerns. Arrange a follow-up appointment to review position and finalize the birth plan, right? And the points that you missed, address emotional and psychological state regarding breech presentation. So once you actually mention something like that to a patient, especially who is a little anxious about her coming delivery, there might be a lot of emotions that might be going on with her. So definitely explore, how does that make you feel? What do you feel about this? Explore that, talk to her about all the ways you can, help with her condition. And, even though it comes with its set of complications, there are a lot of things that you can do to make sure that she has a safe pregnancy, right? Just keep reassuring her, right? Because you don't want her to get stressed out. That comes with its own set of complications, right?
Mhm.
So explain the benefits of ECV, including the success rates, minor risk, temporary fetal distress, and that is done in a monitored setting, and the prerequisites before the procedure, right? Provide leaflets on breech pregnancy and ECV, and safety netting. Finally, advise immediate consultation for reduced fetal movement or any vaginal discharge, right? Any a severe abdominal pain. So three things that we always tell people to do in management, and this is something that the examiners are always looking for as well. Number one, leaflets. The NHS provides leaflets for various different conditions, for various different types of consultations as well. So whenever you are trying to have a consultation with a patient and you've explained a certain condition, you always want to provide them a leaflet so that they can refer to that whenever they go home. So they have a trusted source that they can always refer to, right? Rather than actually, avail information that is out there, which might not always be true. So you want your patients to be educated with the right kind of information. So hence, always try to incorporate leaflets in your, consultation when it comes to management. Start ending with those things. I'll provide you a leaflet with everything that we discussed about breech presentation, about the maneuver that we spoke about, right? So always do leaflets, do safety netting. So as soon as this patient does leave your consultation, she needs to know what to look out for, just in case, if she does experience it, when should she, avail urgent medical help. Those are information that you
Mm.
have to provide this patient before she leaves your consultation. So leaflets, safety netting, and finally a follow-up. After giving a particular treatment plan, you would always want to check out, with them on, yeah, you would always want to follow up with them if how the management is working, right? How exactly is the treatment plan actually working for them? That is something that you always want to check out with them. Yeah. So always try to do these three things in all your consultation. It always, in some form or the other, try to incorporate that. And finally, we have interpersonal skills, which is empathize with the patient's worries and validate the concern, reassure and provide positive reinforcement during discussion. You don't want to excessively scare them. You want to tell them about, the issue and that it can be managed, right? Support shared decision making, reinforce that she will be involved in choosing the delivery method based on evolving circumstances, right? Maintain a calm, non-judgmental tone, ensure a supportive environment so Maya feels heard, safe, and empowered. Summarize key points and offer to revisit any part of the plan. Use signposts while transitioning between consultation aspects. All right, well, that was Gynae, and that was Dr. Ashmi who performed it. So good job, Dr. Ashmi. This was a great first try, I must say.
Great. Thank you so much. Super helpful.
Absolutely. Do keep joining our calls. We will be practicing a lot of different cases on these calls. And also this what we use right now is the OSCE workbench, which you can use to practice with your partner for every case. So you can either practice with your partner using the practice partner mode where you can copy the link and share with them, and they can act as your simulator as well as your examiner. And if you don't have a practice partner, what we have incorporated is a AI that can be your practice partner as well. So I'll give you a short demo of how this AI
Mhm.
works. So once you click on begin time, you will go into this page where you will be presented with the candidate information, and you will have 1.5 minutes to read the question. If you want to skip that, you can skip that by clicking on this button where your patient as they come. So you have to click on this button to start talking. Hi, my name is Dr. Anne. I'm one of the doctors from the antenatal clinic today. May I confirm that I'm speaking with Maya Radfield?
Yes, that's me. I'm Maya Radfill. I'm here for my 36-week checkup.
Hi, Maya. It's so nice to meet you. Could you please confirm your age for me as well?
I'm 28 years old.
All right, Maya, I can see from my notes that you have come in for a routine antenatal checkup. So how's your pregnancy going so far?
It's been going well, actually. I haven't had any discharge or contractions, and my tummy feels fine. I'm still feeling normal movements from the baby. But I'm starting to feel a little anxious as the delivery date gets closer.
So that is your patient, guys. And you can have an entire 8-minute consultation, or else you can press on the end button, where immediately after that, you can get an AI evaluation. So depending upon the conversation that you've had with the AI, you will get evaluated on it, and you will get evaluated on the checklist that we just, saw, shortly a while back. All right. So there you go. There is your data gathering, management, and interpersonal skills. And all these practices get registered according to the date and time of the practice. And if you see here, you can also see a small robot emoji that indicates to you that this was an AI practice. And if you practice with a human, you will get it as a human silhouette. So depending on the case that you practice, your entire presentation will be divided into covered, partially covered, and missed, and management and interpersonal skills the same. And yep, that is your patient GPT, guys. So for everybody who is on this call, we are offering a 20% discount for any of the brain bank products. Currently, we have around 555 cases that you can practice in it. All right. So